just introduce our speakers. So, excuse me. This is Dave Coughlin, who is an assistant professor of neurology or neurosciences, who does a lot of translational research that he brought into my lab, working on digital imaging of neurodegenerative diseases. And Vanessa Goodwill, who is our second year neuropathology fellow, really an excellent fellow. So they're gonna talk, I'll be here today about a very interesting ADRC case that arose for neuropathologic examination prior to my getting here, but a clinician who has since left actually was so curious about the diagnosis. At that time, it was kind of unclear what the diagnosis was, that we worked it up a bit more. So we have a little bit of limited clinical history, but I thought the pathology was interesting enough that we should present this case today. So I'll let Dave start. And by the way, Dave has a 5-day-old newborn, so we really appreciate him being here and presenting this. So thank you, guys.
Great, thank you. Thanks everybody for coming. I think that Annie adequately disclosed some of the disclaimers that I was going to start with anyway. This was not a patient who I knew personally. It was seen by a physician who used to work here, who no longer does it, UCSD. So there are some limits to the clinical information. And also they were enrolled in the ADRC as an autopsy-only case. So we have some info about their sort of general clinical status anyway through the ADRC, but not some of the more granular neuropsychiatric and other data that we would normally collect. But we will talk a little bit about their clinical presentation. There we go. Okay, so we are going to be talking about this gentleman who is a 56-year-old man who came originally to a memory disorders clinic here for evaluation of language and behavioral problems. So regarding his language dysfunction, it started about 4 years before the presentation to clinic. Mother and brother had noticed progressively more trouble getting words out. His sentences were shorter, usually 1 or 2 word answers, no grammatical constructs, a lot of yeses and nos. The content of what he was able to utter was making sense, and there was no nonsense words or errors. He was able to accurately describe items around him, things that he needed or wanted to use. There had been behavioral changes also. There was new and unusual impulsivity with him. He was irritable, getting into arguments or exhibiting frustration, it sounds like, with the family, occasionally confrontational. He was going to Tijuana every once in a while to visit prostitutes. That was a new behavior for him. There may have been some visual spatial dysfunction as well. He was having a lot of trouble with driving a couple of years ago. Before presenting to clinic, he was pulled over several times by police and even went the wrong way on a major San Diego highway once anyway, had his license taken away. And as far as his other activities of daily living, he was no longer able to manage his finances. Those had been taken over by his mother, and he had to be prompted frequently to just do regular cleanliness activities, go in a shower, for example. So there were a number of pertinent negatives. They were denying any visual hallucinations. They said he did not act out his dreams. There's no alterations in his sense of smell, no problems with constipation and urination, no lightheadedness on standing. At that point, he was denying tremor, stiffness, limb weakness or numbness. There were no changes in his gait that the family had noticed anyway, though they did endorse some depression anyway.
Oh, Dave, let me interrupt and say that if people have questions, I think everybody's muted. So just put them in the group chat and I'll try to alert Dave or Vanessa to them, and we can try to discuss them as we go. Thanks.
Yeah, I'm happy to field questions as they come. That's okay. Regarding this guy's past medical history, it was only significant for hypothyroidism. He had an unclear history of alcohol abuse. It wasn't recorded to what degree, how long he had been abusing alcohol, how many drinks he was having per day. It sounded like he had been sober for at least a year or so when he was in clinic, but it wasn't clear if there had been any other complications in the past, liver failure, alcohol withdrawal, seizures, other problems. Regarding his family history, it was negative for frontotemporal dementia. Nobody else had Alzheimer's disease in the family. However, there was his father who was diagnosed with Parkinson's disease at a kind of average age in his 60s, it looks like. For his social history, he was unemployed at that point when he came to clinic, although there wasn't a record of if he was previously employed somewhere. He was not married. He had done some coursework at the University of Iowa, but did not complete his bachelor's degree. Didn't smoke cigarettes. We talked about the alcoholism. They did describe frequent relapses in the chars. Sounds like he was using marijuana occasionally. At this point, he was living with his brother with frequent input from his mother for basically full-time care. And the time that he went to clinic, he was not taking any medications. So his exam, as recorded, was significant for masked facies with a decreased blink rate. His mental status was significant for an expressive aphasia. They said that he was mostly saying yes or no to commands and perseverating a little bit on some questions. He was able to follow commands accurately, but was just slow to do so. They did not notice any cranial nerve abnormalities. Regarding the motor exam, they did notice cogwheel rigidity in both upper extremities. At that point, there was nothing that was written down regarding bradykinesia or other involuntary movements. They thought that his sensation, reflex, and coordination were normal, and they noted that his gait was shuffling. They didn't mention that his frontal release signs were absent, although it wasn't recorded exactly what tests they performed. So at the end of that first clinical visit, they mentioned his assessment being possibly multiple contributing factors, alcoholism, depression. They mentioned cerebrovascular disease in the notes, although I don't see that he had any risk factors for this. But they thought that was most concerning or suspicious for potentially developing frontotemporal dementia. And the plan had been for him to get an MRI of his brain, considering an FDG PET, starting Celexa for the depression, and go to speech therapy for his speech problems at this point. So the MRI happened. Fairly limited sequences were gathered anyway. There were no coronals that were caught. Actually, here's a, oh yeah, so Dr. Brewer, I see a question in the chat. Any eye movement abnormalities? That is a very good question. I'd be interested myself about that. The note that was there did not notice any eye movement problems. Pertinent things to look for a person like this would be slowed saccades, difficulty with upgaze, impaired or absent OKNs would be something one would look for, square wave jerks, round the house signs. Those are all signs that one would see in PSP anyway, but they didn't record any of those items here. So this is a structural MRI. I'm showing you axial cuts of the flare imaging. He had some other sequences that were caught anyway, T1, DWI, GRE. There were no abnormalities that were noted on any of those others. The atrophy patterns that were noted here, so in the context of this 56-year-old person, I think that we would say there's generally more atrophy globally than we would expect for somebody his age. There's no significant white matter changes. And I would argue that the left temporal lobe and left frontal lobe has more atrophy than the right side. You can see that this, if you can see my cursor, some anterior temporal atrophy on the left side compared to the right, dilated horn a little bit down here. When you get up into the lateral ventricle, you can see that this left lateral ventricle is a little bit larger than the right one. The sulci are a little bit more prevalent on the left side than the right side. And if you get up into the upper convexities, you can see this primary sulcus up here being larger, basically, than the other side. So I think there's a little bit of segmental atrophy in this. Yeah, and then Dr. Brewer is mentioning that the midbrain looks a little bit atrophied, so it's a little bit scooped out this way. So some people call that what is that, the Mickey Mouse sign. It's kind of the other version, the axial version of the hummingbird sign anyway. So that's a possibility there. There wasn't a good set of sagittal cuts to really look a little more detail to see if there was like good midbrain atrophy. Morning glory sign, yeah. So we got morning glory sign, or not giant panda. Panda's the other one. Panda's for like a brain iron thing. Yeah. So those are all like atrophy patterns that one can see in PSPs. It's true. So he did end up getting an FDG PET. I'll freely admit that I don't order a lot of these anyway, but this was read as symmetric and otherwise normal appearing cortical uptake, left to right. The significant finding here was that there was markedly decreased basal ganglia FDG uptake in the caudate and the putamen. You can see that there's very little orange in these areas. Up here, there's a little bit of retained posterior putamen activity on the right side. Thalamus looks good otherwise. So the FDG PET was interpreted as being consistent with a Parkinsonian disorder, perhaps even Huntington's, but they are more suspicious of a Parkinsonian disorder of some ilk. So he had one other clinical follow-up visit with the same physician about 3 months later. The interval history looks like things had moved along fairly quickly, honestly. They noted that he was becoming slower, he was falling several times a month. He was now unable to use his right hand for simple things like eating, and he was doing these repetitive movements like combing his hair, and then developed new difficulty with swallowing liquids. At that point, the exam was significant for much worse tone in the right than the left. The right arm had become contracted, and they noted dystonic posturing and looked clumsy with rapid alternating movements. They noticed no right arm swing during the gait. It was just fixed at that point and flexed. And the left arm swing was also decreased. There's not a lot else that was recorded on that exam anyway, but the working diagnosis had been changed at that point to a cortical basal syndrome anyway. And the plan at that point had been for him to follow up in movement disorders clinic and consider a levodopa trial. However, that didn't happen. He lost a follow-up from the clinic anyway. There's no more outpatient visits. He was admitted to a skilled nursing facility a bit later that year. He only has one more contact point with the healthcare system with an emergency room visit about a year afterwards. It sounds like he had a minor fall. The ER notes don't have much of an exam. Otherwise, just mention that he was non-communicative. Nothing else really there. He was not seen by neurology during that ER visit. He ended up being discharged back to his nursing home anyway. The one thing that might be of some interest anyway is that as part of his fall, they did a head CT along with CTing several other parts of his body. And even within sort of the context of comparing some apples to oranges regarding CT to MRI, I think that we can probably appreciate that his atrophy has advanced in the last year anyway. The right temporal horn is now very dilated or atrophied. This is again a 57-year-old at this point anyway. And you can see that the left side is continuing to atrophy. Some of these cortex areas are very, very razor thin at this point. So he's moving along anyway with some right-sided involvement clearly now. So he gets enrolled in the ADRC a few months later as an autopsy-only subject. He passes away about a year after that ER visit due to an accident. I couldn't find any information about what that accident was precisely. At that point, regarding sort of some communications with his family around the time of his passing, it sounds like he was nonverbal and wheelchair dependent. So like I said, as a autopsy-only subject, we don't have a ton of other info to pull from, but the NACB9 form was filled out anyway. So they had noted problems with memory, orientation, executive functioning, attention concentration, all the other items I list here. The behavioral features that were additionally noted was apathy. I guess we got a flavor for that with his difficulty self-prompting to bathe. And then also notice the falls and slowness. They did record a clinical disease rating scale, sum of boxes, with a very high score of 17, significant problem sort of across the board anyway. So to summarize, this is in sort of a single line, this is a 56-year-old man with an overall 6-year course, presenting with a progressive non-fluent agrammatic aphasia variant with additional behavioral features of irritability and impulsivity, who a little bit later developed very asymmetric sounding Parkinsonism with a unilateral dystonic posturing, most consistent with a cortical basal syndrome anyway. I see that there are some questions in the box. So yeah, we're gonna actually talk a lot about that. So there are a handful of other things that I kind of wish that we could have gotten from the clinical information, but yeah, it sounds like there's probably some apractic quality to the hand movements anyway. Hard to say if there was alien limb phenomenon from the exam anyway, but that is something that we'd be very interested in, especially sort of parietal alien limb phenomena. And then I think that, yes, and then we're going to talk a lot about what clinical findings would sort of put us most clearly into this sort of box of cortical basal syndrome-esque things. So let me get over here. So at least as far as movement disorders go, cortical basal syndrome is something that I think is a pretty good disease entity to help highlight the difficulties with clinical pathologic correlations in general. It's kind of the thing that we're the worst at. And I think it really does emphasize in the kind of need for thinking about some of these neurodegenerative diseases in sort of a parallel nomenclature, where you have a set of terms that describe the clinical syndromes that you're looking at in the clinic, and then a second parallel system for the neuropathology that you end up seeing at autopsy. So a cortical basal syndrome has a relatively poor predictive value for having a cortical basal degeneration neuropathology when we're comparing to things like Parkinson's disease or PSP even. And many of these clinical pathologic series over the last 15 or so years show that we have pretty poor accuracy. It ranges from 25 to 70% in these studies. It's a little bit better in some of the more recent work using the more recent clinical criteria from Armstrong in 2013, but even that criteria hasn't been fully validated. So we know that there are several clinical syndromes that can result from a cortical basal degeneration neuropathology, and while cortical basal syndrome is one of them, you can also see it being developed from a PSP Richardson phenotype, some patients with behavioral variant FTD, or non-fluent agrammatic primary progressive aphasias will harbor CBD pathology. And sort of in the other direction, patients with a cortical basal syndrome pathology, that can actually result from different neuropathologies as well, sometimes CBD, but also PSP and Alzheimer's disease, and even others as well. So I thought it would be useful to, hopefully briefly anyway, go over some of the recent or the most up-to-date research criteria that we use to sort of define these syndromes. And the whole thrust of the Armstrong criteria was to help us do better at predicting cortical basal degeneration neuropathology. So it starts by defining some of these clinical syndromes, probable cortical basal syndrome and possible. So you're supposed to have two of either limb akinesia and rigidity, dystonia, myoclonus, and two of the following: limb or orobuccal apraxia, cortical sensory deficits, or alien limb phenomenon. They also define this frontal behavioral spatial syndrome, which can be due to CBD pathology, having problems with executive dysfunction, behavioral issues, sometimes visual spatial issues as well. There can be a significant language component that can be part of the clinical presentation, which tends to be again, non-fluent agrammatic variant of primary progressive aphasia. And there can be a significant apraxia of speech component too. Similarly, there's also some definitions for PSP, as there can be often a fair amount of overlap with PSP and cortical basal syndrome, especially at the end of their disease anyway. These folks often will develop some language problems, but also urinary incontinence and some supranuclear problems sort of at the end of their disease as well. So this is, after you go through sort of the definitions of the clinical syndromes, you kind of put it all together to see what their research and clinical criteria are for predicting CBD anyway. So ideally, you're supposed to have somebody who is above 50 years old, an insidious onset, gradual progression with symptoms for at least a year anyway. Shouldn't be much of a family history at all anyways. There's no monogenic forms that are out there that we know of that causes like familial CBD at this point. And then our patient really fits into this category, as far as you can tell from the chart, although there's suggestions that he might even be more affected. But he certainly seems to have a non-fluent agrammatic variant anyway, and more than one suggestive cortical basal syndrome features, with the apraxia, the unilateral dystonia, the prominent gait issues as well anyway. So he actually fits the more specific version, the research criteria of potentially having cortical basal degeneration. There are a number of exclusionary criteria, the family histories that we talked about, sustained levodopa responsiveness, and arresting tremor meant to exclude patients with Parkinson's, visual hallucinations meant to exclude patients with likely DLB, prominent dysautonomia and cerebellar signs meant to exclude patients with possible MSA, upper and lower motor neuron signs meant to exclude patients with ALS or other motor neuron disease. You can see some upper motor neuron syndrome signs out of corticobasal syndrome patients, certainly, but they really shouldn't have lower motor neuron syndromes, of course. Semantic dementia, and kind of most importantly at the bottom is biomarkers that would be consistent with AD pathology. That was actually the thing that the most recent sort of attempt at validating this criteria actually forgot to do or didn't do, is that they did not exclude patients based on AD biomarkers anyway. So we actually could be better at this than we think potentially. And then very briefly, this patient had a handful of frontotemporal dementia type features, significant apathy and disinhibition anyway. And the neuropathology of BVF2D, in brief anyway, is roughly 50-50, it seems like. 50% will have TDP43 pathology, and 50% will have some version of FTLD tau, with a very small percentage having like frontal variant Alzheimer's disease. And FTLD tau is a basket term that really encompasses many different types of tau-based neuropathologies, PSP pathology, CBD, and some others anyway. The non-fluent agrammatic primary progressive aphasia cognitive presentations are often associated with FTLD tau pathology. This is as opposed to other language variants like logopenic variant, PPA, which is often atypical, Alzheimer's disease, and semantic dementia, which is almost always TDP43 pathology.
Dave, there's two little comments on the side. One that I think is interesting about how, I mean, I don't know the clinical, I'm a neuropathologist, but how movement disorders is suggesting 4-hour tauopathy for kind of the overlap between PSP and CBD. And neuropathologically with the tauopathies, that's exactly right. Like as Dave kind of touched on, we just call them like FTLD tau and then subcategorize as PSP or CBD kind of subcategory. So we also, at least I believe that they're a little bit of a spectrum, and that would be actually more correct to classify that way. And then Jim has a question about frontal atrophy and CBD. I don't know if you want to try to answer, Dave.
Yeah, so I think the answer is sometimes. There's a pretty decent amount of heterogeneity within corticobasal degeneration and corticobasal syndrome anyway. And some of these guys will have significant frontal atrophy anyway. I think it's kind of interesting because, you know, in the movement disorders clinic, we think of PSP and CBS as being atypical Parkinsonian disorders. But in many cognitive clinics, they view them as subtypes of frontotemporal dementia anyway. So I think that speaks a lot to the clinical heterogeneity and where these guys kind of end up anyway. But I guess also speaking to the heterogeneity is that some people with these types of disorders do, I mean, relatively well for neurodegenerative disease with a fairly indolent course over, you know, 5 or more years. This guy seems to have gone down very quickly. At least after he presented to care anyway. Pretty fulminant motor presentation after we started to see him anyway. And that's not unheard of with CBD. You can have some very fulminant presentations, but I do just want to highlight this. This is my last slide anyway of, you know, this is the one that I focus a little bit more on this anyway, because the clinical pathologic correlation is relatively poor. And having some of these augmenting tests with, you know, FDG, or MRIs, other things to try to get a little bit better at predicting the CBD pathology is useful during life because frankly, sometimes it can be other things anyway.
One more question, Dave.
So Etche was asking about AD biomarkers. So the problem is if you look at these big autopsy series, some of the older ones especially anyway, up to 1/3 of corticobasal syndrome is related to atypical Alzheimer's pathology anyway. So, and there is like some not totally well fleshed out evidence that it might be in a slightly different distribution than typical amnestic Alzheimer's disease anyway. But in an effort to be more molecularly specific, linking CBS with CBD a little bit better, this most recent criteria sought to exclude those patients on the basis of CSF biomarkers, and I'm sure that they would add PET to that as well. in an effort really to be more specific for our tauopathies as much as we can during life anyway. But yeah, you're right, Etche. You do, I guess, run the risk of potentially excluding somebody erroneously with sort of age-related pathology that might not be their primary issue. So perhaps in the future, and there is some movement in this direction, a 4R specific marker would be what we would really want for this type of patient population. And yeah, some of the PET ligands are a little bit better. Fluotasapir is not really going to work that well, it seems like, but there's some others that seem to be more promising. And even RT-Quick, there's a 4R variant that people are working with. It's a little bit trickier, but people are working out the kinks. So people are moving in that direction. We'll get there.
All right, now we'll move on to the pathology. Before we actually look at the patient specimen, I just want to briefly go over kind of what we would be looking for histologically in some of the more common neurodegenerative diseases. So first, of course, for Alzheimer's disease, we're looking for neurofibrillary tangles. We can see a nice flame-shaped tangle here, which would be positive for tau. They're also showing some gliosis and a plaque in this field. And of course, in Alzheimer's, it's not just tau. We'd also be looking for evidence of amyloid. Here we have diffuse, abundant plaques, amyloid plaques within the neocortex, but not only plaques, we also have some amyloid angiopathy up here in those leptomeningeal vessels. We'll also look for evidence of Lewy body pathology grossly. If we see any pallor of the substantia nigra, that would be a clue. Here's a very severe case. In a case of Parkinson's disease where there's severe pallor and it's kind of shrunken. And of course, histologically, that'll correlate to severe neuron loss of the pigmented neurons in the substantia and evidence of Lewy bodies with their eosinophilic cytoplasmic inclusions with a halo, and those would stain for alpha-synuclein. We will also look for evidence of TDP43 pathology. As a reminder, normally TDP43 lives in the nucleus, so nuclear staining is considered normal. And so the abnormal pattern we're looking for is nuclear to cytoplasmic translocation, which is pointed out by these arrows here with these rounded cytoplasmic inclusions. And with the tau, in addition to tangles for Alzheimer's, like we talked about, we can also pick up some of the FTD tau, like PIC bodies here shown in Pick's disease. And tau would also pick up other tauopathies like corticobasal degeneration. More specifically, we would be interested in that in this case, also PSP. So here showing the balloon neurons of corticobasal, a globose tangle in the substantia, and some of these tau inclusions and tau threads within the neuropil in CBD. So some things to be looking out for when we look at the patient specimen. So first we'll look at the gross pathology. Unfortunately, I don't have external images of the hemibrain, but it weighed 1,088 grams and was noted to have moderate atrophy of the frontal and temporal lobes on external exam. I don't think the atrophy is too obvious in the cortex here on these coronal sections, maybe a bit of thinning of the cortex, but what really stands out is how small and shrunken this hippocampus is here. You can see it almost looks retracted as well, grossly consistent with hippocampal sclerosis. And what was also noted grossly was severe atrophy of the basal ganglia, specifically the caudate and putamen. The head of the caudate was noted to be almost concave because it was so shrunken, and the globus pallidus seemed less severely affected than the caudate and putamen. Oops. The cerebellum looked relatively normal with normal folia here and the dentate nucleus. The substantia nigra was thought to be maybe a little thin, but we can see it looks pretty well pigmented. It's easy to see here, and then we can also see the locus ceruleus in the pons. Moving on to the histology, this is a section from the middle frontal cortex. There's a bit of artifactual separation of the superficial layers of the cortex here, but even with that, it appears that maybe there's a bit of widening of the sulcus here and a bit of thinning of the cortex. But at higher power, there wasn't significant neuron loss in gliosis. It was relatively mild. And that was also true in the superior temporal gyrus with relatively mild neuron loss. The cerebellum looked normal, so we have a nice population of Purkinje cells here and can see the normal layers of the cerebellum with no significant atrophy. And then this is where things start to get interesting. So here in the posterior hippocampus, we can see the dentate here, CA4, and then when we get around to CA1, it looks significantly pale and shrunken.
And there's just a question about right to left differences in the cortex. And this is actually a limitation of our ADRC, that the brain is harvested and then immediately the right half is frozen. And so we only get the left half fixed. So we unfortunately can't really compare. The gross brain is not examined by a neuropathologist. It's simply harvested and then frozen. And so, although recently Robert has started having gross photos taken at time of harvest, so that will be helpful. This case is a few years old, and so that wasn't going on. And then Jim has a comment, but they're discussing, so we can keep going.
Okay. So again, pointing out here that it's very pale in CA1, and at higher power, we can see there's pretty much complete neuron loss with gliosis, rarefaction, and almost this microcystic appearance consistent with hippocampal sclerosis, which is what we suspected based on the gross appearance of the posterior hippocampus. Here in the entorhinal cortex, we can see the neuron clusters in layer 2, and this is a good place to look for tangles in Alzheimer's disease, which we did not appreciate, and there appeared to be pretty well-maintained populations of these neuron clusters. Looking at the basal ganglia, which again grossly were very shrunken, specifically the caudate and putamen, we can see the correlate of that here with significant neuron loss in the putamen and extensive gliosis, so a lot of reactive astrocytes in this field. So pretty severe atrophy here. In the substantia nigra, there was some neuron loss of the pigmented neurons, and we can see evidence of that with this extracellular neuromelanin over here on the left hand of the screen, but no inclusions, no Lewy bodies or globose tangles were identified on H&E. The pons looked relatively unremarkable. Here we have the basis pontis, normal neuronal populations and white matter tracts. And the locus ceruleus has a pretty well-maintained population of pigmented neurons, and again, no globose tangles or any other inclusions identified on H&E. So far, just to summarize grossly, we have kind of moderate atrophy described grossly of the frontal and temporal cortex with hippocampal sclerosis, and then pretty severe atrophy of the caudate and putamen. And on H&E, so far, we haven't seen evidence of any specific inclusions. So to look further for any evidence of Alzheimer's disease, first we're going to look at the amyloid plaque burden using a beta amyloid stain, which is for the thal phase. So this is the beta amyloid on the middle frontal cortex. This kind of blush hue is just background staining, but we can see there's no actual plaques within the cortex, so no evidence of amyloid in this brain. So next for Alzheimer's, we'll look at the Braak stage, which is the tangle burden using tau. So this is the tau stain in the middle frontal cortex, and again, negative, just like the amyloid, no evidence of neurofibrillary tangles, and also just to note, we didn't see PIC bodies or other tau inclusions. There were a few tangles noted in the entorhinal cortex. This is pretty much all of the tangles that we're seeing just in this one field, but overall a very low tau burden in this brain. So no real evidence of Alzheimer's disease. We had maybe a handful of tangles, no plaques. So overall, this is not Alzheimer's disease pathologic change based on the staging. So again, it got phase 0 for all thal, Braak, and CRED staging. So we don't have evidence of tau or amyloid. So next we look for evidence of Lewy body pathology. Again, on H&E in the substantia, we didn't see Lewy bodies. So we also do an alpha-synuclein stain. This is done in the amygdala, And you can see there's no abnormal alpha-synuclein staining, so no evidence of Lewy body pathology. And then we'll look for TDP43. So again, normal TDP43 is in the nucleus. This is a section from the superior temporal gyrus. And you can see these all show normal nuclear staining with no nuclear to cytoplasmic translocation. So far, no evidence of TDP43. And here in the dentate gyrus as well, normal nuclear staining with no abnormal inclusions. So far, again, we don't have evidence of Alzheimer's disease. We don't have evidence of Lewy body disease. And in terms of the subtypes of frontotemporal dementia, on our tau stains, there's no evidence of a tauopathy and no evidence of TDP43. So once we've kind of run up, that's our usual panel of stains. To look further for other abnormal protein accumulation, we can use a ubiquitin stain. So that's what was done next. And this is a ubiquitin stain in the dentate of the hippocampus. And you can see there do appear to be inclusions in the cytoplasm of the granular neurons in the hippocampus. And they're quite abundant within the dentate here. There was also a rare ubiquitin inclusion seen in the CA4 as well. So when we look at the classifications of frontotemporal lobar degeneration, as was talked about earlier, the vast majority of them are accounted for by tauopathies and then TDP43. So we know that we don't have evidence of tau accumulation and we have no evidence of TDP43. So that leaves us with these two much less frequent categories, which is FTLD FUS and FTLD UPS. And FTLD UPS is when you have ubiquitin positive only inclusions. So the next step to decide which of these categories this case may fit into is to perform FUS staining. So this is the FUS stain in the dentate gyrus again, so where we saw those ubiquitin positive cytoplasmic inclusions. And again, we see very similar shaped cytoplasmic inclusions with the FUS staining. So there is evidence of abnormal FUS accumulation. In addition to cytoplasmic inclusions, there were also quite a few nuclear inclusions that have this linear to kind of curvilinear or serpiginous pattern. And this is again in the dentate in the hippocampus, and they were also seen in pyramidal cells in CA4. So overall, now we do have evidence of frontotemporal lobar degeneration, and we have identified that the protein here is FUS. And we believe this case fits best with atypical FTLD with ubiquitin inclusions, or AFTLDU, which is a subtype of FTLD FUS that I'll discuss going forward. And again, no evidence of Alzheimer's disease, Lewy body, or TDP43 pathology. So what is FUS? The FUS protein is a member of this FET protein family, and FET just stands for the three members. So FUS is fused in sarcoma, EWS is Ewing sarcoma, and TAF15 is this TATA binding protein. And so all of these were originally identified as genes often mutated in certain sarcomas, such as Ewing's and myxoid liposarcoma. And what's known about this FET protein family is that these proteins are ubiquitously expressed DNA RNA binding proteins, and they continuously shuttle between the nucleus and the cytoplasm, but in neurons and glia are predominantly nuclear. And so what's interesting about FTLD FUS is that if you perform stains for the other two FET protein family members, the EWS and the TAF15, you'll see that not only are these inclusions aggregates of FUS, but there's also co-aggregation of those other members. So you can see that in this example here, where we have positive staining for FUS, EWS, and TAF15. And so this category of frontotemporal lobar degeneration can really be reclassified as FTLD FET rather than FTLD FUS, because it does involve all three of these proteins. And there's three pathologic subtypes, which we'll talk about. But what's interesting is to date, no cases of FTLD FUS, to my knowledge, have been associated with a mutation in the FUS gene, although FUS gene mutations have been associated with certain forms of ALS. And so what causes FUS to accumulate in the cytoplasm and the nucleus isn't really known, but they have shown that it appears to be somewhat dependent on the methylation of an arginine at the C terminus of FUS. And so normally FUS lives in this dimethylated state shown here at the bottom. And when you stain for the FUS aggregates, you'll see that they co-localize with the unmethylated FUS form in this merged image on the right, versus there's no abnormal aggregation of the dimethylated FUS form, which is thought to be the normal state. And so this paper here was looking at why FUS accumulates in FTLD FUS and also comparing that to ALS FUS. So normally FUS, again, is in that dimethylated state, and it interacts with this transportin, which is this TNPO1, to shuttle into the nucleus. However, when you lose that arginine methylation, it seems that the FUS cannot interact with the transportin and can't make it into the nucleus, and that there's also enhanced phase separation and aggregation when you have that loss of methylation. And this is completely different than what happens in ALS with FUS mutations, where you have an actual mutation in the nuclear localization signal that prevents FUS from being transported into the nucleus. So going back to the pathology of these entities, the FTLD FET, there are 3 different neuropathologies associated with the accumulation of these FET proteins. The first is AFTLDU, which is atypical FTLD with ubiquitin inclusions, which is what we believe this case to be. And this is the most common form of FTLD FUS in Western countries. And so these are some of the classic features you'll see on pathology. So here are those cytoplasmic inclusions that are common in the dentate, which we saw in our case, as well as these kind of curvilinear nuclear inclusions. The second form is neuronal intermediate filament inclusion disease, which what separates this is that the inclusions not only stain for the FET proteins, but they also stain for intermediate filaments such as neurofilament. And the last is basophilic inclusion disease, which is actually the most common form of FTLD FET in Japan. And as the name tells you, it has these distinct basophilic cytoplasmic inclusions, which you can see an example of here, which again would stain for the FET proteins. So here, this paper is looking at all 3 of these FTLD FET subtypes and comparing the kind of clinical presentations of these patients. And if you look at the age of onset, you can see all of these patients present at a rather young age, kind of 20s to 40s. And for AFTLDU, the mean here they had was an age of onset of 37 years. They also had a rather rapid progression of disease. And what's interesting here is when you compare the presenting symptoms. So in AFTLDU, you can see that all these cases presented with a behavioral variant of frontotemporal dementia and did not have significant motor symptoms, and they also didn't have any significant language symptoms. That's different than the neuronal intermediate filament inclusion disease, where they often have primary progressive aphasia and will occasionally have motor symptoms like Parkinsonism or ALS, and basophilic inclusion disease, where again, there's a higher proportion of patients with motor symptoms. And here they're comparing the pathology, looking specifically at the neuronal cytoplasmic inclusions within these 3 subtypes of FTLD FET. So all 3 subtypes can have the cytoplasmic FET inclusions within the cortex. Of course, if you have intermediate filament positive inclusion, that points you towards NIFID. And if you see abundant basophilic inclusions, which tend to be subcortical, that's typical of basophilic inclusion body disease. And here they're comparing the localization of the intranuclear neuronal inclusions, so those linear inclusions that we saw in the dentate and CA4 in our case. And you can see anything that's in gray was significantly different between these entities. So neuronal intranuclear inclusions are more commonly seen in the cortex and striatum in AFTLDU, which fits with our case in the sense that we had very severe atrophy of the caudate and putamen, and I didn't show it, but we did find a few nuclear inclusions within those areas as well. And as we saw in our case, the hippocampus was severely affected, both the dentate and the CA areas, and that can be seen in both AFTLDU and NIFID, but is not typical of basophilic inclusion body disease. So as I showed before, when presenting the clinical scenarios for these cases, the majority of AF-TLDU presents with behavioral variant frontotemporal dementia, and they tend not to have motor or language symptoms. And as far as I know, no case of corticobasal syndrome clinically has corresponded to an AF-TLDU case. However, there was a case report in Japan of a patient who presented with corticobasal syndrome and was found to have basophilic inclusion body disease, so one of the FTLD FET subtypes. So I think what this shows us is just like the chart that was shown earlier, is that we can add to the list of neuropathologies that can clinically present with a corticobasal syndrome. So in summary, AF-TLDU is a pretty rare pathologic entity. Only about 5 to 10% of FTLDs are attributed to these FET pathologies. And typically AF-TLDU has a very early onset of behavioral variant frontotemporal dementia, often at an age less than 40 years. And it's usually very rapidly progressive in terms of the psychobehavioral changes. And it's typical that there's an absence of significant motor or language features. So our case is interesting. It does have some features clinically that correspond to what's been reported in the literature for AF-TLDU, and that the patient did initially present with psychobehavioral abnormalities suspicious for a behavioral variant of FTD, and did have a somewhat rapid clinical progression. However, he also had a bit of atypical clinical presentation than what's been reported. His age of onset in the 50s was a little older than a typical case of AF-TLDU, and he also had significant motor symptoms and aphasia, which of course raised the clinical consideration of corticobasal syndrome, but is not classic for AF-TLDU. So not only is this kind of a rare pathology that we're seeing in this case, but also his clinical presentation is quite unique. And that's all I have.
Yeah, so just to summarize, we're excited about this case. We are writing it up because we think that the clinical features are pretty different from most cases of AF-TLDU, particularly the later age of onset, the motor features, the language features, and then the pathology is also kind of different. Most of these cases have more striking inclusions in the frontal and temporal lobes. This really hit the striatum, the caudate, and the hippocampus is kind of typical. So the other thing I wanted to say about this case is just that Don Pizzo really helped us out because we didn't have FUS as a stain. And actually the early examination of this case, the ubiquitin wasn't strong enough to pick up those ubiquitin inclusions in the dentate. And so Don actually helped me a lot by getting both of those stains going, allowing us to actually make this diagnosis and write up this case. So I thought the pathology was pretty exciting and pretty unique. I don't know if other people have questions for these guys, but they worked hard on this case. So.
I think it's awesome. I think that's just, I really love the way it was presented, really nicely done, and love the new staining that the staining approach that we're doing to get to the bottom of this. Glad we got this individual. Might not be a UDS case, right? Or because I'm just wondering, because it might be interesting to go ahead and get whole genome sequencing on the tissue, and we may not be able to do that through the NICRAD, but we probably would go ahead and just invest and say, let's get that, you know, if there's an interesting mutation in that, because this is a weird case. And it's also strange that so much of this is so young and yet not really clear genetics at this point, I guess.
Yeah, that's right. There aren't. And so these, as Vanessa mentioned, these patients, although they have the FUS aggregation, don't have FUS mutations, or at least so far haven't. The other thing that's a little interesting that we really weren't able to look into further is that the patient's father had a history of Parkinsonism. it's just kind of like this, you know, thing that could be really interesting, but we don't have more evidence.
So if you have trouble getting it sequenced through NICRAD, maybe we should talk about just taking this to the Institute of Genomic Medicine and getting whatever you feel like you need sequenced.
Oh, and I guess the other thing we should say is that recently, like in the last few months, this guy who works on FUS a lot published 2 cases that were a little bit closer to this, of a FTLDU with FET inclusions, that were a little bit closer to this in that they were later onset, so patients in their 60s, who I think had a little bit longer clinical course, which is kind of unlike our patient, and also had a bit less of the like cortical pathology, though they weren't hit as hard in the striatum at all. So it just seems like now, and these cases are rare, like I think, you know, reports are of AFTLDU are, you know, dozens, not, you know, hundreds. But we're kind of broadening the picture of what the pathology and the clinical features can be.
I like what Dave said about sometimes it depends which neurologist you see first, whether it's a behavioral neurologist or a movement disorder physician. But in this particular case, I think it could probably be argued that he presented with PPA and BV-FTD, that was the clinical syndrome, and it was present for many years, probably before he developed a clear Parkinsonian syndrome that in a way was the end stage of his disease.
Yeah, what we're really not sure of is kind of what was going on prior to that first visit, you know, because the course was precipitous. I think it was just a couple years from first visit, but yeah, we have no idea what was actually percolating in the background prior to this.
Annie, that's terrific. Thanks very much for figuring out exactly what that thing was. I'm just curious, people kind of seem to underemphasize the hippocampal sclerosis component. It just made me think that in frontotemporal lobar degeneration, TDP-43 late, there's the hippocampal sclerosis, and that has something to do with I guess, the nuclear to cytoplasmic translocation of a protein. And this guy had really severe hippocampal sclerosis. So do you have any hand-waving explanation for why those nuclear to cytoplasmic translocations of 2 different proteins would both produce such severe hippocampal sclerosis?
Yeah, I don't, but I like your observation, because it is totally true that Larry's talking about this kind of new pathologic entity that accounts for a lot of dementia called late, where there is frequently a lot of hippocampal sclerosis in these kind of old patients who start off diagnosed with Alzheimer's, but often don't have enough Alzheimer's pathology to account for their clinical features, and then end up having TDP-43 translocating from nucleus to cytoplasm. And they often have very bad hippocampal sclerosis. So again, it does seem like this guy had the same thing. Yeah, this nuclear to cytoplasmic translocation of various proteins does correlate with this really striking hippocampal sclerosis. Yeah, but I have no mechanistic insight into that.
And we've been going back and staining our hippocampal sclerosis cases for TDP-43, but if there's ones that don't turn positive for TDP-43, maybe we should think about this. I don't know.
The thing with hippocampal sclerosis that is hard is, right, I always talk to Larry about this a lot, like you see it in Alzheimer's too. It's just like you diagnose it when the gliosis and kind of tissue destruction is out of proportion to the Alzheimer's change there. So yeah, I guess it would be interesting to look at the cases without strong Alzheimer's features, but with hippocampal sclerosis. I bet a lot will have TDP-43. And then this.
And I think we'll find that out, right? I think we are. I thought we were going back and staining our non-Alzheimer's hippocampal sclerosis cases, or maybe all hippocampal sclerosis diagnoses with TDP-43 just to catch that. And this would have been one where we would have been perplexed because there's no Alzheimer's, no real vascular. I don't think there was a vascular etiology or anything else to explain why the hippocampal cells were dead, and we would have had to go down this path.
You know, when I talked to the clinician, it was Shauna Yan who left. I was like, I'm positive this is going to be TDP-43. Like, let me just stand in for that. We'll get an answer and done. And yeah, it definitely wasn't. All right. If there are no other questions, I'd like to thank Dave and Vanessa for their good work on this. And we'll present another one of these in, I don't know, a few months.